So thank you, Marley Bauer from Innsbruck, Austria. She will be also our moderator today. And of course, thank you also to Stefan Motto from St. Gallen, Switzerland. And he will be also in the roundtable. Of course, I want to say thank you also to the ENS office, to Nico and Anna Rek, who help us in the technical organization of these webinars. And last but not least, I want to say thank you also to Host Design Company that decided to support this webinar. So I think we can start. So Marley, the floor is yours. Please, I hope you will enjoy this webinar. Thank you.
Thank you very much, Giovanni. Well, as you just said, it's our third webinar this year. I'm very happy. And today is all about decompressive craniectomy and cranioplasty. So definitely a hot topic in our everyday's work. Before we get started, I'm going to go through some housekeeping rules to ensure that you can interact with myself and the speakers. If you wish to ask the presenters a question, please click on the hand icon or ask a question in the Q&A forum. So we have an open chat feature enabled, and simply click on the button. For time's sake, we will discuss the questions after the talks, if there are not any burning hot questions. So let's start with our work. First of all, I want to introduce Jussi Posti. He's a neurosurgeon at Turku University Hospital in Finland. And he's doing a lot of TBI research and has a lot of TBI research background. Jussi, please.
Thank you, and thanks for the introduction. Just a minute, I will share my screen. Let's see if this works. And here we go. So I will discuss DC and address some updates, pearls and pitfalls, and I will also have a couple of remarks on non-TBI indications. So first, a couple of words about epidemiology, since this is tightly related to the subject. A decrease in the incidence of TBI has been observed in the United States and Europe during this millennium. However, the global TBI incidence is increasing as the population ages in the West, and in developing countries, urbanization and traffic is causing more victims of TBI. But still, the median age of TBI patients has nearly doubled since the 1980s in high-income countries. But this leads to the situation that the incidence rate of admissions of older adults with TBI is increasing, but the severity of TBIs is decreasing in almost every study, not depending on the country or region. Here's a population-based study from Finland, which we did last year. And you can see here that the incidence during 2004 to 2018 of evacuation of epidural hematomas, subdurals and intracerebral hematomas is going down in both genders. And the same applies to all acute trauma operations. But the only operation type is DC, whose incidence is actually increasing over time. So this means that we are doing less mass lesion evacuations and more DC. So this is why this topic is actually quite acute. Couple of words about the basics on DCI. As you know, the intracranial volume includes brain tissue, blood volume and CSF. And the volume of these compartments is rigorously regulated, and CPP is maintained by cerebral autoregulation. When the physiological equilibrium is disturbed by expansion of some of these volumes, compensatory mechanisms are activated. So it looks like this. In normal case, the compartments are here, and in compensated situation where edema or mass lesion appears, the ICP remains normal for some period of time, but if the edema or mass lesion enlarges, the situation becomes decompensated. So in these cases, after maximal medical therapy, we use DC, or at least most of our institutions do so. And DCs can be, they can be primary or secondary. Primary means that the decompression procedure is combined with an evacuation of space-occupying lesions, or in case of initial diffuse swelling, the decompression alone. This is done to prevent postoperative ICP increase. Whereas the secondary, the most common DC, is an intervention that is a part of tiered therapeutic protocol in ICU setting to reduce intractable ICP and ensure adequate CPP. This is done to reduce morbidity and mortality. Here's one case of mine, 29-year-old male. He was previously healthy. Couple of years ago, during springtime, he fell from his summer cottage's roof and hit his head and sustained an isolated head injury. Upon arrival of an ambulance helicopter, his GCS was 3. As you see, a diffuse injury, lots of swelling, and I did a DC, and during the 2 hours of procedure, the secondary brain damage has progressed. But still, even though the image looks quite bad, he still had at least somewhat favorable outcome. I would say goes E5. He is able to cope at home, but without this procedure, he would have definitely died. So this is quite a basic case, but what do you think, what's wrong with these cases? In patient 1, what's the problem? You can say.
It looks a bit small.
Yeah, definitely, it's too small. So the brain is bulging from the decompression hole. But what about in case B? What's the problem here? I would say it's too wide. There's no support for the brain. And in case C, this looks quite odd. But what's the problem? Well, the problem is that the decompression goes over the midline. It causes problems every time. So that's why Brain Trauma Foundation says that large frontotemporal parietal DC is recommended over small DC for reduced mortality and improved neurological outcomes. And many authors, such as De Bonis and, for instance, myself, say that cranial border of craniectomy should not be closer than 2.5 centimeters to midline to decrease a possible risk of postoperative subdural hygroma or hydrocephalus, like in this case, or maybe also in here. Here's one figure from a book I co-authored a couple of years ago. It's actually the Scandinavian Severe TBI textbook. These are different skin lesions that can be applied in case of DC. I usually advocate the skin incision A to preserve the normal circulation and try to preserve the temporal artery. And in figure D, you can see the decompression. I usually use 3 burr holes and make sure that the floor of the the middle fossa is decompressed down to zygomatic arc in order to decompress the temporal lobe and prevent ankle herniation. And please remember this 2 and 2.5 centimeters to midline in order to prevent post-traumatic hydrocephalus. So let's go to the current evidence. I will talk talk about Rescue ICP and DECRA, which are the largest RCTs so far and whose methods and findings supersede those of smaller studies. They both studied secondary DC, but in DECRA they did it quite early, whereas in Rescue ICP it was used as a last resort. Both of the studies have yielded follow-up papers, which I will address too. But let's first go to DECRA study. This was published in 2011. They included patients with GCS below 8 and diffuse injury on head CT. And if ICP was over 20 millimeters mercury over 15 minutes, they randomized. And they randomized patients to have a bifrontal decompression or maximal medical treatment. The main findings were that outcome at 6 months in the surgical group, 70% of patients had unfavorable outcome, whereas in the medical group, 51% had unfavorable outcome. In figure A, you can see the surgical group had a substantial decrease in ICP after time point 0 at the decompression, but it did not yield to favorable outcome in most of the patients. As you can see, the cutoff here is GOSI 4, and there are more, actually 70% of patients in as a cumulative proportion having unfavorable outcome. They also published a follow-up study including 12-month results, but unfortunately DC increased vegetative survivals and decreased survivors with good outcomes compared with standard intensive medical therapies at 12 months. In 2016 came the Rescue ICP. It was a somewhat larger study, and they used randomization if ICP was over 25 for 1 to 12 hours, actually quite long, despite of maximal medical therapy. And then they randomized. And patients were randomized to surgical group in which frontotemporal parietal or bifrontal decompression was employed. And the other group had maximal medical treatment. The outcomes at 6 months showed that in the surgical group, 43% had favorable outcome. Also, more vegetative states were observed. In the medical group, 35% had favorable outcome, but in this group there were less vegetative states. Here are the graphs from the first paper, and as you can see here in the surgical group, if GOSI 3 or above is used as cutoff, there are more favorable outcomes in the surgical group, which is actually maintained over time. Then the follow-up study was published, and the panel below, there are the 24-month results showing that patients in the DC group had sustained reduction in mortality and higher rates of vegetative state, severe disability and moderate disability. But the patients in the DC group were more likely to improve over time compared with patients in the medical group. This was a new finding and actually quite interesting that patients are doing recovery at least up to 2 years. I was always thought in medical school and during my residency that the final result usually after trauma procedures can be observed at 1 year, but that's not the truth, as you can see here. So the interpretation goes like this. These are of course my thoughts. Both studies basically examined the effect of secondary DC, but in DECRA, patients underwent early decompression if ICP exceeded 20, while in rescue ICP, decompression was used as a last resort. And in case if ICP was persistently over 25. And only rescue ICP 24-month results show that patients with DC improve over time. At least in my humble opinion, the criticism of DECRA study includes that they used bifrontal decompression. I personally think that this is one of the key drivers of the unfavorable outcomes seen in the study. And another issue is that 27% of patients in the surgical group had fixed pupils, whereas in the medical group only 12% had. And decompression was performed on some patients even if medical options were available. And in that study, there were 23% of crossovers, meaning that they shifted to surgical group if they looked bad. And in terms of the rescue ICP, the criticism include that the decompression technique was done at surgeon's discretion. And the study included patients who had previously undergone hematoma evacuation, so there were actually really secondary operation patients. And they used different, I would say a bit more optimistic outcome threshold than usually. So based on these studies, and actually excluding the 24-month outcomes from rescue ICP, the Brain Trauma Foundation reported the following. There is level 2A evidence to improve mortality and overall outcomes. So that secondary DC performed for late refractory ICP elevation is recommended to improve mortality and favorable outcomes. And secondary DC performed early refractory ICP elevation is not recommended to improve mortality and favorable outcomes, meaning that they recommend that DC should be done after maximal medical treatment. And they also recommended large decompression over small decompression. And there's also level 2 evidence for ICP control. Secondary DC done early or late is suggested to reduce ICP and the duration of intensive care stay, through the relationship between these effects and favorable outcome is uncertain. I think this is quite conservative interpretation, but still clinically valid. Then a couple of words about DC in stroke. Multiple RCTs suggest that DC for large hemispheric infarct, when performed less than 48 hours after stroke onset, reduces mortality and improves good functional outcomes in patients aged 60 years or less, whilst the rate of disability is higher in patients over 60 years of age. And DC after 48 hours does not carry the same benefit as early intervention. And early imaging studies, including MRI and CT perfusion, should be used. So this figure is from one systematic review describing the mortality in the medical and surgical groups in all the RCTs, including younger patients, and of course the effect is quite drastic on mortality, but of course the effect is not that significant on favorable outcome. Then a couple of words on DC in subarachnoid hemorrhage. As you know, these patients are prone to develop high ICP in case of severe bleeding and edema. There are no RCTs on this patient group, but there are some actually quite many observational studies. And a recent meta-analysis suggested that approximately 10% of patients with SAH undergo DC because early or late complications of aneurysm rupture. And younger patients with good grade SAH have a better outcome after DC. Well, this is not surprising, and it actually seems to be quite universal for different reasons for intractable ICP. And especially in these cases, primary DC seems to be superior to secondary DC in terms of outcome. And there seems to be at least one RCT ongoing on DC in subarachnoid hemorrhage. And regarding the other indications, I know that in Finland and in my institution we have done DCs for variable indications such as severe meningitis or sinus thrombosis, but the cases are quite heterogenic, and they usually DC has been used as a last resort treatment. So there is, I wouldn't say that there is any convincing evidence on DC in these indications. Well, I stop here, and thanks for your attention.
Thank you very much for this nice overview. We have already a couple of questions in the Q&A section, but I think we will discuss it afterwards. We go ahead with our next talk, which is done by Alexander Krieger. He's from Innsbruck, and he's part of our young faculty here. And he's involved in the German cranioplasty registry and is overseeing some research projects on cranioplasty as well. And he's talking about cranioplasty, risk factors, complications, pearls, and pitfalls. Alex, please.
Oh, thank you, Marlies. So, dear colleagues, now we're going to speak about the next step following decompressive craniectomy, about cranioplasty. The first and the main question should be the indication for it. Obviously, we want to provide a mechanical protection for the brain. Moreover, the CSF circulation could be improved. And the last, but nowadays not least, the aesthetics does matter. On the other hand, the main purpose of our surgery should be neurological improvement. How cranioplasty can achieve it? Dynamic studies of pressure and blood flow have showed that the hard-covered skull negotiates the impact of atmospheric pressure. That leads to increased blood flow, which finally results in neurological improvement. In this study, TCD was performed before and after cranioplasty. The significant blood flow improvement was found in the contralateral MCA. Thus, cranioplasty works not only locally, but is able to provide the functionality of the healthy side. One interesting case was presented in Geneva last year. The patient developed sinking skin flap syndrome. Due to infection, the cranioplasty stayed impossible. As alternative, a negative pressure helmet was applied. That resulted in lower ICP and consequently higher cerebral blood flow. The next game-changing question could be, when should we perform this surgery? Let's take a look on this review article. Here, the patients were divided into two groups. Early, if cranioplasty was performed within 90 days after decompression, or late otherwise. The Bartle index was significantly higher if cranioplasty was performed within 3 months. The same results were found for Karnofsky performance status. And finally, similar trend was revealed for functional independence. Okay, we can agree that we shouldn't wait too long with cranioplasty. But what does it mean to be early enough? You may follow that cut-off between early and late has been variously defined. In this article was described that infection rate is significantly higher if cranioplasty was done within 2 weeks after decompression. From the other side, the risk for seizures and, as we have just discussed, neurological improvement is lower if we wait more than 3 months. Perhaps should the cranioplasty be done just after the decompression wound is healed? In the first study was shown one more time that functional outcome is better if cranioplasty performed within 12 days. In the second one was shown that the infection rate remains higher if you do not wait 7 weeks by any patient with comorbidities. So the optimal window for cranioplasty would be 7 to 12 weeks after decompression. Then infection risk is already lower by all patients and neurological improvement still remains higher. The next important point is the material that should be used for the flap. The discussion and arguments for or against patient-owned bone flap versus different synthetic materials are well known. Moreover, if we use synthetic material, handmade technique or manufactured implants could be used. We can probably begin with autologous bone flap. It is biocompatible, cheap, and according to several studies provides similar infection rate. From the other side, it needs to be stored in a special biobank. Due to remodeling, should be reimplanted not later than 1 year after removal. And of course, bone flap resorption is the main disadvantage. The risk for it is about 3% per year. It comes more frequently by younger patients with CSF shunt and if bone flap was fragmented during trauma or the initial removal. Let's take a look on synthetic alternatives. First of all, PEEK. It's inert, mechanically stable, and is associated with lower complication rate compared to autologous bone. Nevertheless, the high risk for seroma formation was reported. Another known material is PMMA. It's widely used not only in medicine. For example, this power station was built using PMMA, providing good mechanical and thermic isolation, even in extreme circumstances. Nowadays, it's commonly impregnated with antibiotics. It is also inert, and what is important, it doesn't cost much. It can be used as viscous liquid that could be quickly prepared directly in the operation room, or it can be pre-ordered in the finished hard form. The main disadvantage of it is that during hardening, it becomes hot. This could result in thermal denaturation of the superficial cortical tissue. And if no prepared model is used, the artistic skills of surgeon do matter. To avoid these complications or disadvantages, you may use pre-ordered PMMA flap. However, it costs more and requires some more time. Instead, what do? We ask our physics department to print on the 3D printer the negative model of the skull. We use the fine slide CT scan, mirror the healthy side, leave the place for the flap, and calculate the level of the bottom. In the OR, in the same time with the dissection, the liquid PMMA is applied on the stereo model, and exothermic correction is not an issue anymore. The bone flap is finally removed from our negative model and reimplanted. Please take a look on this example. It's a young guy after TBI. 2 months later, he didn't have any neurological deficits, and his autologous bone flap was reimplanted. However, you can see what happens afterward: progressive bone resorption. Thus, the revision with PMMA, as I have just described, was performed. Another option for cranioplasty flap is titanium. It's very stable and, as you know, inert. Nevertheless, the popularity of this material is decreasing, mainly due to skin decubitus. Biocompatible materials based on calcium phosphate or hydroxyapatite could be also used. It was described that even after fracture of the flap, it can grow together by itself. Good. The main part of this talk actually should concern complications. The rate is varies in different sources, but is always reported to be too high. In this evaluation with 8.2 thousand of patients, we can follow that each third patient had at least one complication during the first month after cranioplasty. But at least the early postoperative mortality stayed low. Our center participated in prospective German cranioplasty register with about 500 patients. During intra-hospital stay, each fourth patient had any complication. This rate was higher in case of repeated cranioplasty. Surgical revision was necessary for almost every 10th patient, and the overall mortality rate was 1% during the same hospital stay. The median stay was about 6 days. However, in case of revision, it was about 3 times longer. And here are our intra-hospital revisions. The most frequent cause of surgical revision was epidural hematoma. That took about 20% of all complications and about 40% of all revisions. Let's take a look on the risk factors for any early revision. Increased MRS or ASA score were independent predictors for it. Notably, ischemic stroke as the underlying diagnosis was associated with a minor rate of revisions compared to TBI. Now we are going to one particular problem, CSF drainage impairment. It comes in about 18% of cases after decompression. Thus, many patients require both surgeries, cranioplasty and CSF shunt implantation. We evaluated our internal data and searched for all patients who experienced both interventions. In 14 cases, they were done during one surgery. In another 16 cases, cranioplasty was followed by CSF shunt implantation. Afterwards, we searched for intra-hospital revisions. In the first group, 7 cases were reported. Another 8 cases were reported in stage procedure. Still, the revision rate during hospital stay was terribly high, but it remained same in both groups. We didn't find any impact on revision rate considering type of the injury, age, comorbidities, material, site of implants, as well as MRI score. We also asked ourselves when is the optimal point for shunt implantation after cranioplasty in case of stage procedure. According to ROC analysis, the intervention rate heavily increased after 26 days. Okay, after this pessimistic result, let's go to conclusion. Cranioplasty can provide neurological improvement. It should be performed within 2 to 3 months after decompression. Perhaps earlier only if patient has no comorbidities and primary alteration has been completely resolved. There are different materials available for the flap. Nowadays, there is a shift for synthetic materials, mainly due to lower revision rate, especially resorption. Nevertheless, the complication rate is very, very high. Also, revision rate is terrifying. Here, worse MRS and ASA score and used autologous bone flap are risk factors. Finally, if you want to implant a CSF shunt to a patient requiring cranioplasty, it should be done in the same time, or at least not later than 1 month after it. Thank you.
Thank you very much, Alex. That's a very nice overview of cranioplasty and shunt. I think we just go on with our last talk today, which is performed by Mario Ganau. He's currently a clinical lead for neurosurgery for the Southeast region of England, based at Oxford University Hospital. And he is the head of adult neurotrauma there and has been recently, I'm very happy for him, elected as ENS chair of the Ethical Legal Committee. Mario, please.
Good afternoon, everybody. I think you can see my slides. I will start saying I do not have any conflict of interest relevant to this talk, and basically the aims for me would be to discuss biases in interpreting the literature results. We have heard from UC and from Alex what is the background on both a primary, secondary decompressive craniectomy and cranioplasty. I'm going to provide a critique of the literature and highlight some biases. We will reflect on the ethical challenges of both decompressive craniectomy and cranioplasty, and I will present a quality of life, a patient-reported outcome measure questionnaire specific for cranioplasty that we have adopted here in Oxford. And I will anticipate some results from the literature coming up in 2024, particularly with regards to cranioplasty. So let's start with the literature. We have heard a lot of results from randomized controlled trials and systematic reviews and meta-analysis. Obviously, they provide the highest level of evidence. However, they are prone to some biases as well. And obviously, only by identifying them, we can really appraise the literature and the take-home message that we can bring in our clinical practice every day. So let's start with the listing some of those biases. One is a survivorship bias, which is our natural tendency to highlight successful outcomes and disregards failure. This is particularly typical of surgeons and neurosurgeons. Confirmation bias, we all seek out and prefer information that resonates and supports our pre-existing belief. And external validity, obviously, many studies downplay issues with sample selection and sample size, hence they fail to represent the world at large in real life. So it's difficult for us to have some generalizability of those studies. So this letter was written in neurosurgery just after the publication of Rescue ISCP. It compared both trials, Rescue ISCP and DECRA, and obviously question whether we are much wiser or not after those randomized clinical trials. And the problem is that effectively, yes, we have heard from UC very well what are the outcome of those two studies. And he has also shown this image from the update at 24 months after Rescue ICP, demonstrating that the outcome of those patients continues to improve in form of Glasgow Outcome Scale Extended. However, the question is, what really is a favorable outcome? And we have this article on Journal of Neurotrauma from Zuckerman, Giacchino, and Bodian. And as you can see here, basically, they highlighted how different authors considered different thresholds for a favorable outcome. You might have at the bottom of the slide some authors that are very conservative. They consider only upper severe disability in the basically range for favorable outcomes, so a range between 7 and 8, and some others, like the first row of this table, indicating that any outcome other than death or vegetative state was considered as a favorable outcome. So it's difficult to appraise the literature if there is this extent of heterogeneity in the studies. Another example, confirmation bias. This is regarding primary DC following removal of acute subdural hematomas. The conclusion of Rescue ASDH was that additional surgery was more likely in the craniotomy group, whereas wound complication was more likely in the craniectomy group. And then you have the editorials which accompany the article. This was written by Professor Gopinath from Baylor College of Medicine. And interestingly, he said, with these results, I expect surgeons will be reassured that it is relatively safe to perform the quicker procedure and remove the bone flap. On the other hand, this is the a statement from the University of Cambridge. They concluded that this international study recommends replacing the skull after evacuation of the brain bleed. And we have one of the authors, a very good friend of mine, Professor Collias. He says this procedure will save patients from having to undergo a skull reconstruction at a later stage. And obviously we know that cranioplasty carries the risk of complication and additional healthcare costs, as Alex has nicely reported. So here you have the very same study that has been appraised very differently by very eminent professionals in the field. So how do we interpret in our day-to-day life? another study that has been reported before by Alex. This is basically a study from Malcolm et al. About timing of cranioplasty. And it is true, as previously shown, that Malcolm demonstrated that patient operated early for calvariate reconstruction tended to have a better outcome. However, we have done a secondary analysis of this data and demonstrated that, for instance, if you consider the Bartel index, which is an index for independence in activity of daily living, those studies, yes, they were showing a tendency toward a more favorable outcome for early decompression. But when those studies were analyzed, as we did through a funnel plot, and you can see it on the right, there are 3 studies out of 5 that fall outside the triangle. And even those that are within the triangle are very far away from the midline. This indicates that those studies are so much heterogeneous. We concluded that it is difficult to find any external generalizability. And therefore, we concluded in our article in our commentary from neurosurgery that there is a debatable role for classification, ultra early, early, intermediate, late. And believe me, I might do any of them depending on the clinical needs of the patient, but my guiding star is that cranioplasty should be performed whenever patient is ready. So what is the ethical conundrum regarding DC and cranioplasties? Here I put my hat of chair of the ethical legal committee. Let me present this case. We have this 59 years old female, previously fit and well, and unfortunately she's admitted to hospital with VITT. You may remember we had a rise of this kind of condition in 2020, 2021, just after the global vaccination for COVID-19. And some of those patients developed vaccine-induced thrombocytopenia and thrombosis. Here we have this lady admitted with a right hemispheric ICH. She has a GCSP of 2. You know, GCSP means a GCS of 3, and we remove 1 point because one pupil is unreactive. But this is not her only problem. She has DVT, she has right lower lobe PE, she has a thrombosed right hepatic vein. The question here is it appropriate to consider evacuation of the ICH? Is it appropriate to consider a decompressive craniectomy? And eventually, by considering the values, the beliefs of the patient, after long discussion with the next of kin, we decided to go ahead with the decompressive craniectomy. As you can see here, very nice evacuation of the ICH, a relatively good decompression. As you can see, a very satisfactory decompression of the temporal pole, and the CTA confirming that the thrombosis extended also intracranially at the level of the transverse sinus and sigmoid sinus. Now the question would be, would we have considered the very same surgical approach if this lesion was on the left? Would we have done the same if the patient was much older, say 80, 85 or plus? Well, it's very difficult to find an answer for this, but I want to draw your attention to this article. The senior author here is Marike Brockman. She has been a long-standing committee member in the ethical legal committee and former IMC chair. And her research basically demonstrated that in neurosurgery, we tend to offer less and less withdrawal of care to our patients compared to medical patients admitted to intensive care unit. And here the research question was whether this was a missed opportunity for our patients. And from an ethical point of view, she has a valid point. How can we improve cranioplasty pathways and how can we embed patient perspective into surgical care? Well, as you know, any surgical outcome requires a comprehensive analysis. We should consider surgeon-related aspects, we should consider procedure-related aspects, and patient-related aspect. And we can perform either a quantitative or a qualitative appraisal. Usually a quantitative assessment is based on hard figures. For instance, we can consider what are the surgical or medical challenges specific for that patient undergoing the surgical intervention. We know that the risk for cranioplasty may range between 30 and 50% depending on the series, but we can also perform a qualitative appraisal. And so this means understanding what matters to surgeons and particularly what matters to patients. We have written this paper on Surgical Neurology International, and we have advocated for setting up structural cranioplasty pathways as a means to reduce complication in cranioplasty surgery. This means that we believe there should be a dedicated surgical team for cranioplasty and potentially involving also plastic surgeons and maxillofacial surgeons. And in our own experience, this is making a difference. I'm going to show you how it is possible to find some commonalities between a structural cranioplastic pathway and a complex system. Now, a complex system is a system where multiple actors influence each other's and basically represent different nodes in the pathway. And obviously there are some aspects that matter the most to our hospital managers, particularly the timing through which the patient transition in the pathway from admission to discharge, time of follow-up. But there are some other aspects that are relevant from a clinical governance point of view. In Oxford, we have a very strong cranioplasty MDT, which includes both surgeons, neurosurgeon, plastic surgeons. We tend to involve patient in the decision-making process, particularly with regards with materials for cranioplasty. I tend to show them different materials and highlight the pros and cons of each of them, unless I have a very strong mind about a specific material. If I'm in equipoise, I welcome their point of view. And then obviously the importance of cranioplasty registries in order to reduce basically heterogeneity. And then patient journey. This is the most important aspect, how patients perceive their journey from decompressive craniectomy to cranioplasty. And again, this is a very specific quality of life, a patient-reported outcome measure questionnaire that we have initially adopted in our pediatric population. Is FACE-Q craniofacial. This is a questionnaire that can be obtained from Canadian University. You can ask for the license. And will help particularly with cranioplasty because it's specific for some aspects that matter to cranioplasty patients: symmetry of the eyes, symmetry of the ears, aspect of the forehead, smiling, ability to chew, etc., etc. And no other cranioplasty questionnaire is able to provide this depth of information. The others can only tell you whether the patient is satisfied or not, but they are very much generic. What to expect in 2024, and I conclude, and I say this is particularly relevant for cranioplasty surgery. We should start standardizing outcome measures for cranioplasty surgery. And there is this article from Harry Nee. He has been involved in setting up the UK registry for cranioplasty, and is involved in several other research specific to this area. Basically, the aspect that they have put at the center of their trial is identifying core outcome set. So the minimum standard of information that we should have regarding outcome of cranioplasty in any study reporting on this type of procedure. And then this other research effort, which has been led by Professor Servadei, former President of the World Federation of Neurosurgery, and Professor Iaccarino from the University of Modena and Reggio Emilia. And again, we have carried out a consensus conference with a modified Delphi process, and many experts in the fields, colleagues from Cambridge, colleagues from Birmingham, and so on and so forth, are from Edinburgh, are involved into this in this consensus conference. We are trying to identifying some recommendations on the management of cranioplasty in patients with post-traumatic hydrocephalus. And just to, break news to you, one of the aspects that we have identified is that it would be better not to have a PP shunt at the same time of cranioplasty. And this is contrary to previous evidence from the literature. So there is a lot that we will discover in the near future in 2024. It is always important to have a critical approach to the existing literature. And from my point of view, always trying to keep ethical aspects in mind in decision-making process and any type of treatment for our patients. Thank you very much for your attention. I end here.
Thank you very, very much, Mario. This is really good talk. I'm very happy. I'm very pleased that all of you could join today. We can see it in our Q&A forum. There's a lot going on, and I think we're gonna go over some questions which were asked in there. First of all, I want to welcome our panelists in our roundtable as well, who could join today. I think we're gonna go just with the first question. And there are two questions about bilateral DC. What do you think about that, Jussi? Do you do that often in Finland, or don't you do that at all?
Actually, when we started doing DCs in 2007 and 2008, when I started my residency, we had actually lots of problems with the bifrontals. The most common problem was that we usually used it for patients with bilateral frontal contusions and edema, and in these patients we saw actually quite many times that the superior sagittal sinus was compressed due to edema, and these patients quite often developed some ischemic lesions due to that. And the cranioplasty also was quite troublesome. But the question is always about surgery, and as you know, in surgery, surgeons advocate different techniques, and usually based on the preference, which are the familiar procedures. But I would say that at least in our institution, and maybe in Finland overall, we don't do bifrontals anymore due to the many post-operative problems and problems related to cranioplasty. But like I said, there is not much hard evidence on this subject. It's more like a surgical preference. Thanks.
So you have to decide whether do the right or the left. You decide on the CT findings and go on, I guess.
Yeah, exactly. And usually I would say that in most of the cases, it's quite easy to determine which hemisphere is more severely injured. And that side should be selected for decompression. And that's why I don't see that much of room for bifrontal decompression nowadays. But like I said, it's my humble opinion.
Mario, do you have an opinion on that?
Well, I also agree that if possible, it's better to avoid the bifrontal decompressive craniectomies. They are more challenging also in terms of reconstruction. They tend to give a little poorer outcome. And in those cases where you have, sudden improvement from the patient in the early postoperative days, you kind of wonder whether it was the right strategy or not. Just to give you a bit of insight, we have basically we have created a classification of the complexity of cranioplasties, And bifrontal cranioplasty for us is more complex than a simple unilateral, obviously. And for all those cranioplasty, we also always tend to involve also either a max fax or a plastic surgeon, because the cosmetic outcomes obviously will matter more. And from my point of view, if possible, obviously I would always try to go for a unilateral decompressive craniectomy. Yes.
Well, the aesthetics are really important right now. We had a lot of abstracts at the annual meeting in Barcelona doing questionnaires and stuff on this topic as well. So I think this is a really hot topic in the next couple of years.
I totally agree. Yeah.
I have a question for you, Jussi, and also for you, Mario. When you perform a decompressive craniectomy, do you perform a cut on the sagittal sinus? Because I know that some surgeons prefer it in order to decompress the frontal lobe more adequately.
Yes, and it decompress the anterior commissure and therefore improve the outcome, because it allows a better expansion of the brain, controls better the ICP as well. Obviously, it's more technically demanding. So the question becomes, would I let my trainee at night performing this independently? If I really trust them, yes. Otherwise, I will have to come in and help, or the patient will have a bifrontal decompressive craniectomy without opening the falx.
In my case and in our institutions, we don't do those, since we have tried to standardize the procedures, because they are usually done by the residents and during the night hours. And at least as a senior and a trainer of young neurosurgeons, I consider that standardizing these procedures is actually of paramount importance. And I'm not saying that I don't trust our residents, but I think that the decompression only is usually adequate. But of course, I also emphasize that there are cases when you should employ those techniques.
If I may, there is another aspect that we have not discussed this afternoon, which is the cysternostomy. This is again another challenging practice, has been described by Hype Chirian when he was practicing in Nepal. Now he's in India, excellent skull-based surgeon. And again, this demonstrates that some of the technical skills required for this type of surgical intervention might not be available anywhere, and certainly not in the hands of very junior residents. Those aspects need to be considered when we appraise the literature and when we take decisions for our patients as well.
Evangelos, please.
Hi, thank you. Great presentations and very, very informative. I had a question. There was something mentioned at the beginning that we tend to do more decompressions now. And obviously, we have data that say, we described the data and we discussed about it. My question is, do we think that the fact that we have improved our cranioplasty technique, we have tried various materials and we do have good results, and in general, we feel more confident with doing cranioplasties now, does this contribute to the fact that we tend to do decompressive craniectomies, a bit easier than how we used to?
Again, if I may, this the increase in the need for decompressive craniectomy reflects the way we have changed our practice following evidence from the literature. And the second aspect is that I think there was a lot of effort in standardizing operating procedure in each unit, training our juniors so that they can work independently and perform this surgical intervention anytime, day or night. And then obviously there are some other specific variation to the technique, like the ones that we have described, cutting the falx, doing a cysternotomy, etc. But they are still a niche, and I believe there is in the future a margin for improvement by incrementing their use in treatment of our patients, depending on their needs.
Laura, please.
Hi, everyone. I'm so happy to see this is crowded and plenty of people are attending because it's so important. Like, so many interesting questions have been asked. I have a couple of questions for all the panelists. So I'm glad that we're talking about materials because this is very important. There is no current consensus regarding superiority or clear indication of superiority of a single material. But I would like to hear about your experiences because there is a different rate of implantation of materials depending on countries in Europe, and also the ethical issues and the maybe also medical legal, but it's more ethical, I believe, of operating and decompressing and preparing an elderly patient for this path, which is very complex and invasive and requires lots of rehabilitation. So I would love to have your opinions.
Who goes first?
I think I can start. So in Austria, there is no standardized procedure how we are going to go cranioplasty, what material we are going to take. As you saw, we usually use PMMA cranioplasty and alternatively use autologous bone flap. As the second decision, after bone resorption, mainly we use only PMMA, and we do not buy it. We are preparing the material by ourselves, so the cost is not a problem anymore. But I know that in other hospitals in Austria, other materials are used, and some clinics have even their own 3D printers in the department, and they're printing not the negative model as we do, but they are printing the positive model that's being reimplanted. But here we need to discuss the problem of approval of EMA and FDA, because you implant the material inside what was produced by you. We use negative model and we implant the normal PMMA, so we avoid this problem. But this is the main problem that do have other clinics that use positive model. Thanks.
And if I may continue, the situation in Finland, and I would say in most of the Nordic countries, is that we primarily use synthetic materials. And in Finland, we usually use titanium or bioglass, which is actually a Finnish invention. But I know that in many Nordic countries, PMMA and PEEK are widely used, but I would say that we don't primarily use autologous bone due to problems in terms of resorption.
That's a good point. First of all, the resorption of the autologous bone is quite high sometimes, and not every clinic or not every hospital do have an biobank, I guess. Stefan, you just raised your hand.
Yes, I just wanted to ask, there is an ongoing study I heard about when surgeons are not replacing the bone flap, so they're putting the bone inside with and suturing it with a small distance so that they can expand when the cortex is expanding also with a brain edema. What do you think about it?
So
you're not removing the bone at all.
Yes. So technically, this is called Eans craniotomy. With my colleague Salvatore Kibber from University of Strasbourg, we have collected a huge cohort of patients. We're going to publish very soon, but the article is currently in submission. obviously this would represent a very good alternative to the decompressive craniectomy. There is low quality evidence out in the literature about Eans craniotomy. I think would be a very valid point, particularly in the elderly. And this might address the ethical question that was previously raised by Laura. And from my point of view, if I can go back to the various materials, I agree there is no material that address all patients' needs. And there are variation, regional variation, national variations. The UK registry, for instance, demonstrated a very high rate of titanium cranioplasty, not just because of the material, but also of the surgical technique, which is something we have not described this afternoon. A titanium cranioplasty is an onlay technique for calvarial reconstruction, differently from any other materials that requires an inlay insertion of a cranioplasty. The inlay cranioplasty obviously puts the patient more at risk of extradural bleeding, which is one of the main reasons for revision surgery, because those extradural collection might cause mass effect and compress on the ipsilateral hemisphere. So there are various aspects that needs to be considered. I don't think it's just a matter of materials. However, I would never use a titanium cranioplasty in a patient that is at risk of regrowth of a tumor, or in those patients where I do single stage resection of a tumor and reconstruction. And the reason is that titanium can give some artifacts in the postoperative MRI and follow-up, and can be on its way if the patient requires adjuvant radiotherapy or radiosurgery. So in those circumstances, I usually prefer to have a plastic, either a PEEK or, which is my preference, or even acrylic, so that you can use a cutting guide, perform the craniotomy, remove the tumor, and then you have your plastic cranioplasty that will fit well the craniotomy and will prevent the patient from having a second stage procedure.
Laura, I think you raised your hand first. I think she has a bad, never mind. You see.
Yeah, thanks, Mario. Great remarks on the material and the implant type. Just one more addition that many studies show that these so-called inlay implants, since they need more dissection of dura, the operation times are longer, and that might affect also the rate of infections. And one additional comment on titanium: even though I really actually like titanium, it bears some problems related to temperature, for instance. As you know, in northern countries, we like to go to sauna, and it tends to heat in sauna, and the same applies in the frozen weather. It gets really cold. And we are actually gathering evidence that it seems that patients who have multiple metal allergies, let's say allergies to 2 or 3 more metals, it seems that in these patients, titanium can cause subcutaneous thinning over time, and it might lead to exposure of implant, not in acute phase, but like after 1 or 2 years. That's an interesting phenomenon and needs to be studied more extensively. But thanks.
Thank you for your comment. There is a second topic, like peaking in our Q&A forum, which is the age of the patients. Do you guys and Laura, do you have like a limit of you don't operate on 75, 80 years old? Do you have like a guideline in your hospital?
So basically, this is as I was saying, this is a huge questions ongoing everywhere in European congresses. So this is a problem. We don't know. We tend to look at the patient as always, and as it works for young people, it works for elderlies. But it's easier to decide when a patient is too frail and is not fit and has too many comorbidities. However, when you have 80 years old that were running marathons the day before, this is the real problem. When you can really not assess the way in which they might recover. We know that anyway, the elderly people is more at risk of developing a lot of complications. So we don't have cutoff, but after 75, we strongly require at least collegial decision. We talk with each other. We tend not to decide by ourselves, and also we involve families. This is my most important recommendation: involve families in decisions, because this is a long way, and the patient will need a long way. If everything goes well, the patient will need a long way. If everything goes wrong, which means the patient can die, but also the patient can stay in a vegetative state on not a really nice outcome that we expect, the patient needs still to be involved. This is a huge ethical issue, I understand, and I hope that European Registry of Trauma could provide more insight regarding that.
Go ahead, Michael.
Yeah, I have two comments regarding age. Well, first of all, we have, I think, to think about the biologic age, not the calendaric age. So many people are quite fit with 80, and some people are quite old with 60. The second thing is we have to think about the atrophy of the brain. So many old people don't require decompressive craniotomy. In the case of ICH, of subdural hematoma, and simple evacuation of the hematoma is sufficient in actually most cases. And about subdural hematoma in old patients having anticoagulants, actually they have sometimes very good prognosis. So usually they don't have this massive brain damage as young people after a car accident, and they have only small bleeding for one small cortical vein, which can be addressed quite quickly, and they recover quite good. So you don't know from the beginning if it's going to be bad or a bad outcome or a good outcome. I have actually operated on people that are 80 or 90 with subdural hematoma, and they had very good outcome and left the department to their houses. In the case of a stroke, that's totally different because you have a very big brain damage. And actually, one of the randomized trials, Destiny 2 trials, showed that elderly people don't profit from DC as good as younger patients. So all the other trials were on younger patients, I think till 60 or 65. And Destiny 2 showed not as good results as in the other studies.
Just a quick comment now on Laura's earlier comment on talking to the relatives. That's always a bit troublesome because sometimes you ask them and talk to them, how was your dad or how was your mom before, and they always tell us, yeah, they were good, and that's not always true, I suppose. So it's quite hard to talk to the relatives and ask them for give us a solution on what we are going to do now. Don't you think?
I completely agree with you. That's why we should develop some kind of standardized questionnaire for families to better understand the real quality of life that this patient was having beforehand. So it should be this should be a nice project for our group. we should develop this. We should develop some kind of reliable, standardized questionnaire to provide to families in order to achieve real answers, not how was this patient, it was good, it was fine, he was going to buy his newspaper every morning. It's a different thing. So something that really we can be able to better assess those patients.
Stefan.
Thank you, Marlies. First of all, I totally agree with you. I think it's an individual decision and you have to take into consideration a lot of different factors if you tell the patient or the relatives what exactly you want to do. And I have also a question from our Q&A section, which is really interesting, I think. Is there any published data regarding cranioplasty rates during the initial COVID pandemic, especially during lockdowns? As I can imagine also that there were some critical delays in those procedures. Mario, do you know something about it, or maybe Jussi or Alexander?
So there is no evidence in the literature simply because we have not published yet about this topic, but we know that during the pandemic, all elective surgical intervention were put on hold, and obviously calvarial reconstruction by definition, unless you have a syndrome of the Trefine, represent an elective surgical intervention. So patients had to wait months and months. My personal experience, I have not noticed any impact on clinical outcome as a result of this delay in cranioplasty. And this again reinforces my view that the cranioplasty should be performed when patient is ready, rather than binding our decision to a specific timing after the decompressive craniectomy. The second aspect is many custom-made cranioplasties have an expiring date. There are some cranioplasty can be re-sterilized and others cannot. And as a result of the delays during the pandemic, many cranioplasty plates had to be discarded, and the patient had to wait even longer for a new cranioplasty to be printed and manufactured by the companies. For this reason, we have changed our practice. We do not perform CT cranioplasties on discharge. We wait until the patient is ready for cranioplasty surgery, and we try to have the CT cranioplasty as close as possible to the elective surgical date, so that we can ensure the cranioplasty plate is fit for purpose and really match the defect. And this is because, as we have heard, there is an issue of remodeling of the edges of the craniotomy, the craniectomy, and this might either be in the form of resorption or at times calcification. Particularly in young patients, you might notice a significant calcification of the dura, to the point that at times you have to take into account those hiles of floating neoformed bone on the dura, which might affect the cranioplasty surgery, particularly if you opt for an inlay plate.
Thank you. Any more comments on this topic?
I think that also the question during Corona pandemic should be about intensive care unit. The main problem was actually not the surgery by itself. The problem was a place afterwards. So I want to ask my colleagues, do you observe the patient in intensive care unit after the surgery or not, as we do? Because by us, it was the main issue during Corona, that we didn't have ICU place for them.
If I might go first, even though we know that cranioplasty is one of the most risk-associated procedures in neurosurgery, even though it's actually quite simple surgery, and some people might even argue whether it's neurosurgery at all. But we, in the beginning of 2010s, we had cases with epidural hematomas, but since we shifted to use onlay implants, we don't have that kind of complications that often anymore. So that's why we usually observe them in the recovery room, not in the ICU. So the pandemic was not a problem, at least in our institution here in Turku. Thanks.
Well, actually, we had the same problem as in Innsbruck, and during the pandemic, we stopped taking them to the ICU, and they are monitored as every patient in the recovery room, and then can go to the ward. So we don't have more complications than in the past. It happened actually to many other surgeries too, like stereotactic biopsy, for example.
And did you stick to the
Yes.
Yeah. So they don't go any longer to the ICU to recovery and then on the ward,
Yeah, actually, we published our experience about a couple of months ago in JNS, and we noticed that taking the patient to the ICU is not mandatory in many cases. We still do it for brain tumors, but not in other conditions. Yeah.
Okay. Well, then I think we can conclude today. We have about 1.5 hours of webinar, which is really, really a good topic, a hot topic, and we had to discuss a lot. I'm very happy all of you could make it here, and we had record-breaking participants and listeners today. I'm very happy all of you could join, and I'm hoping you're going to join on the next webinar in December. Thanks all. Thanks for coming. Thanks for sharing your sharing your slides and all your input. Thank you.
Thank you. Bye.
Yeah, thank you.
Thank you.
Bye-bye.
Bye.
Thank you very much.
Thank you. Congratulations to everybody.